In this talk today, I want to share my study of the changing science and travel of facts about COVID-19 from a mostly US point of view, and how deeply it has sometimes been misunderstood here, especially about time. Some of the things I want to cover are: how did many countries get this so wrong? Why is COVID-19 so strange? Can we learn? And by we, I mean the US. And what should I be paying attention to in terms of living with COVID-19 and my current attempts to answer these? So here's the current state of the world visualized by the Financial Times. It shows the day-by-day changes in total deaths by global regions. Since November 1, there's been even more deaths per day than at the previous peak. Then, as now, Europe and the US were the largest contributors. This chart from the New York Times shows the current rate of cases in the world. How many cases for every 100,000 people in a region? Beyond major malicious screw-ups like Trump, almost all of Europe is doing terribly now too. Many of the European countries did quite well at the beginning of the crisis and then started reopening, and that seems to have gone very badly. Just last week, the map used a scale that went to red at 14 cases per 100,000, which made all of Europe and the US look the same. Now they've spread the color out and still had to add more detail, add more reds, all the way up to almost black. This is because the scale of infection is so different by region. Returning to November 21, we can note how much of the world has a rate that is below 4. Many of the countries in Asia and Africa are below 1. Some, like China, Thailand, and Cambodia, Chad, and Niger, are at 0, while the US is at 57. There are additional concerns about testing rates, but it is increasingly hard and stupid to hide a pandemic. And Europe is in the middle of an explosion of cases, but still very different by region, from 5 in Finland to 43 in Sweden to 70 in Austria. These are differences of over 10 times. Some in the US have pointed to its being in the European range at 57 cases per 100,000. I'm ashamed to continue to realize how much my US Eurocentric training makes me think there's a mistake here, rather than recognize that countries that are doing well have learned from previous experiences with outbreaks and maintained a vigilance against them, as well as they have not politicized mask wearing and other public health measures to the point where basic civil compliance for collective health is rejected. Canada looks relatively good here in terms of cases, but its death rate is also quite bad. Every country that is not the lightest yellow is in dire straits. In September, for instance, the United Kingdom found that less than 20% of people told to self-isolate actually did so. I suspect the rate in the US is even lower. As was just reported in Australia, a single case can quickly grow, and more so as people have reasons to lie about their contacts. In fact, the scale to show the state or county rates in the US are so much bigger that the world scale had to be shrunk. The high end of the country rate for the world was 68, but in the US it is 250. San Francisco is right now at 14 cases per 100,000, New York at 21, but much of the Midwest is 10 times more, over 200 cases per 100,000. These were areas that were relatively virus-free early in the summer, but as they welcomed mass gatherings, in-restaurant dining, and rejected masks, their cases exploded. Seriously though, every county is endangered because of their base rate and travel. Everyone needs to participate in getting the rates down everywhere. Maps are very tricky to read. I've chosen the previous maps because they show rate, the number of cases per day. Here's an example of maps that show totals. The top one shows the death total by state since January, and the bottom the totals for last week. They seem informative, but what they are really showing is population. California and Texas have the most deaths because they have the most people. Here are those total maps next to the rates per 100,000 since January in the top right, which still shows the effect of New York and New Jersey's deadly March and April. The bottom right shows the death rate per 100,000 last week. Now the Dakotas are highlighted. I've added the case rates now to the further right, which now show in the bottom right the horrifying rates over 150 throughout the Midwest. It is so bad that it has already overwhelmed the overall rate since January, such that New York is no longer standing out. This unfortunately portends a death rate to come in 4 to 8 weeks for the Midwest, as those cases overwhelm hospitals. I do not want to imply that all total maps are bad, but they are very misleading if you want to know where situations are bad and getting worse, and why. The graphs that show changing rates of death and cases illustrate this and are worth contemplating and comparing because they show just how extreme the differences and similarities are. So, why do these maps look like this, and why can't many of us seem to even understand what is happening with COVID-19 infections? I want to get a sense of the depth of confusion, and to do this I think we need to understand how we got it wrong in the beginning. Then we can change the overall messaging and understanding, perhaps. The most important thing is that when COVID-19 initially appeared, it was spreading weirdly. It didn't match other illnesses, including SARS. One explanation was that it was being spread by surfaces, and when researchers looked closely, there was virus on surfaces. China sprayed disinfectant on entire blocks with large trucks and armies of people in hazmat suits. But as researchers around the world kept studying the epidemiology of who got sick and how, in case after case, surfaces didn't match the patterns. I've spent time trying to find maps, graphs, and illustrations that make these insights clear. The Spanish newspaper El País has some of the best. In an office building in a call center, for instance, in Seoul, South Korea, there was a case where an infectious person sat at a large table with 12 other people in a call center. The room was big, but over the course of the week, 9 of the 13 employees tested positive. The call center room ended up with 79 of 137 employees, almost 60%, testing positive. Importantly, on the other side of the same floor, only 5 employees tested positive, and only 3 others on other floors, despite the fact that all of these people shared lobbies, elevators, and other communal areas. Cases like this, studied in detail, led to the understanding that shared infectious air over time was the primary cause. This illustration shows the issue. If you are infectious, even without symptoms, and in a small room, your breath slowly fills it with aerosolized virus, that is, virus floating on micro-water particles that float in the room, and they become increasingly concentrated as time goes by. In a restaurant, one infectious but asymptomatic person had dinner with a family. Later that night, the person would show symptoms. After the meal, 9 other customers became infected. Many were much further than 6 feet away. The size of the restaurant was not the only issue. There was an air conditioning unit that circulated the air in a fairly restricted way, sort of ensuring that one side of the room breathed the same air, spreading it amongst them. The ones who got infected were also there for almost an hour or more. Those that were there for a shorter time did not get infected. This is a starting point to understand that just getting exposed to virus is not enough. It appears that our bodies can handle a small dose. But if we get too much, it sets up camp and reproduces in us, and often in our breath. For some of us, our bodies then react violently, causing symptoms as well, and sometimes death. Here's a first simple equation. How much dose, in how small an area, over how much time, and with what ventilation, helps to figure out how much risk you are at. Time matters so much, and yet it is barely talked about. Why? In an animated short video, Chenjing CL asks a critical question. Why doesn't the CDC focus on time? And what about masks? El País provides another example of 6 people gathering in a living room. One person is infectious, and they hang out. 4 hours later, that room has enough virus in it that the rest will have become infected. If they all wear masks, after 4 hours, it is likely that 4 out of 5 will still be infected. In other words, masks alone will not prevent infection if exposure to accumulated virus is prolonged. If they only hung out for 2 hours, however, and there's good ventilation, as well as wearing masks, such as an open window and door, the odds are that one person will be infected, even with masks. This is partly because air does not circulate smoothly. Like eddies in a river, some virus can still accumulate to an infectious dose. Does this mean that masks don't work? No, that is not the right question. Unfortunately, shared air is not a question just of masks. It is masks and time and ventilation and infectious people combined. It is not rocket science, but reducing it to do they work or not work is stupid and frankly evil. What do masks do? There's a lot of science about masks that you can look into, starting perhaps with Lindsay Marr. On Twitter, she has been collecting and sorting the studies. At a basic level, masks stop particles, such as aerosolized viruses attached to water droplets suspended in the air. Not by being so small, the masks, as to prevent them from getting in, but by interrupting their flow and by catching many of them, sometimes most of them, in various ways. Masks are not perfect, but that is okay, if you think with the idea of infectious dose. An infectious person spreads the virus by breathing aerosols and by coughing droplets. By catching a lot of the aerosols and droplets, a mask reduces the amount that are produced by the infectious person into the room, and they catch ones that the rest of us breathe in. I've summarized some of the research here. There are N95 masks that stop 95% of aerosols. And then there are surgical masks that stop 67 to 80%. And then there are cloth masks that stop 50 to 75%. The key thing is that even if people are wearing only cloth masks, this means that between in and out they are stopping 75 to 93% of the viruses. And this reduces your chance of getting that infectious dose by that much, which can be more than enough to prevent transmission, to prevent you from catching it. So, in a hotel in Switzerland, several guests had the virus, and many of the staff were exposed to it. But only those people who wore plastic face shields were infected. But those who wore masks were not. In other words, shields alone do not filter the air you are breathing. But masks do. The CDC investigated a situation where 2 hairstylists were infected with COVID-19. One had given it to the other during maskless coffee breaks, and that one had given it to her family members at home. They also saw 139 clients during the time that they were infectious for more than 15 minutes. But everyone was wearing masks, the hairstylists and their clients, and none of their clients contracted COVID-19. To repeat, both of these are true. Masks work. They can greatly reduce transmission, but they also cannot 100% prevent indoor transmission. Other behaviors are needed too. When a politician or a scientist says that masks aren't a silver bullet, they are saying the second part of this, that they can't 100% prevent transmission, but they are implying the first part isn't true, and that is a terrible and terribly wrong implication. The more masks are worn in public, most or all of the time, the less COVID spreads. There are so many myths about masks, and media loves to repeat these because you click on them. We don't want to wear masks if we don't have to, but we do have to, and we need to learn to want to. If you want me to put it simply, masks help, and helping not only matters a lot, but it can stop the virus spreading. And not wearing a mask increases everyone's risk, and it leads to this map. Here's another kind of safety chart. And this is a chart for people who are asymptomatic. If you are coughing, you should not be seeing others. For this chart, if everyone is wearing masks and outside and at a distance, all is good. Even well-ventilated indoors for a little while is okay unless you are shouting. But things get risky as ventilation is poor inside, or if you share the air for longer. If we add people and there's not enough room to maintain distance, that space is filling up, then it gets quite dangerous, especially as you spend more time, even with masks. If masks aren't worn by everyone, however, then even a short time indoors is dangerous, especially in unventilated rooms, even if just a few people. And if the room is crowded, even outdoors at a crowded bar, for instance, where people are shouting to be heard and often taking off their masks because they are drinking, this will include sharing droplets of spit as well as air over time. So, the same equation, masks matter, time matters, crowds matter, and inside ventilation matters. The very best recommendation is that any gathering be outside with distance. This alone can stop infections from rising. I'm still trying to find confirmed cases of outside spreading beyond bars. If they exist, they are exceedingly rare. Being outdoors reduces the aerosol concentration so much that an infectious dose is very, very hard to achieve. Now, many people immediately ask, what about this White House event in which all those people with red circles got COVID? It looks like they got it outside. But even though the picture makes it convenient to circle all those people at the same time, media coverage sometimes ignores the fact that many of those people, especially all of those VIPs in front, were inside with each other for a while, in close proximity, talking loudly without masks. The picture of the outside spreads the wrong message about the risks of outside versus inside. So how did we screw this up so much? Oh, The Guardian reported that less than 20% of people in England self-isolate fully when they surveyed, and I'm very afraid that in the US, the rate is much more. We all like to think that we know enough that we can make small exceptions for ourselves. That's what increases the transmission rate so much. Behind the scenes of hand sanitizers, COVID-19 was behaving differently from its virus relatives. Surfaces weren't transmitting it, but air was. But it was different. And this is critically important for how the virus continues to spread so rapidly in many countries. We think about new things, we scientists and all the rest of us, think about new things by modeling them on things we know. If we have the wrong model, we not only don't understand, we often misunderstand. So the first big problem with COVID-19 is that it took longer to show up in someone who was infected. Even SARS was only 2 to 7 days, rather than COVID's 2 to 14 days. The flus are very rapid, 1 to 2 days often. And this is how we have come to feel that infection works. Anything longer than a week is really weird. It's hard to hold cause and effect clearly when we have the model of short infection time. The 14-day quarantine practice provides the best chance to find symptomatic people, in that it seems to find 99 or more % of cases. Unfortunately, however, even worse with COVID-19, many or even most people are infectious, and most infectious before any symptoms. Before, in other words, they have the slightest idea that they might be sick. This is terrible for human behavior, especially for anyone who thinks they know their body. SARS and the flu both are most infectious after symptoms, so we have tended to internalize the idea that we are a good person if we stay inside or home when we feel sick. And this, being infectious before any symptoms, also means that temperature screening is not a good means for preventing spread. It is helpful, but a lot more is needed. And when someone with COVID-19 is infectious, they are sometimes super infectious, and that is super infectious before they feel anything. And a third deadly difference we're now all aware about is that many people don't ever get symptoms. Without testing, they would never know they got COVID-19, and therefore they can spread it without ever knowing they were a vector. And again, this is really different than SARS and the flu that public health and we think with. A fourth surprising difference is that super spreading events are deadly, but relatively rare. One person who is super infectious breathes with others in a confined space long enough without masks, and many of them get it, and then they spread it to others. But they don't spread it to all of them. Over and over again, it seems that many people, perhaps 70% who have a COVID-19, never spread it to anyone else, even when they live with them. One explanation of this, that does not have enough research, is that viral load, how infectious someone with COVID-19 is, varies by day and maybe by hour. The yellow lines in these charts of 9 different people show different peaks of infectiousness in the days after onset of symptoms. The height of the line is exponential, so they sometimes go from incredibly infectious to not infectious in one day, or from not infectious to incredibly infectious in one day. And many of them never become infectious enough to spread it. So this exponential variability of infectiousness over time also makes it very hard to think with. It means you can't trust previous non-infectious gatherings to be a guide that you won't get it next time. Infectiousness is really annoying in this regard. Researchers have not yet found any guide to who will be super infectious, nor when they will be super infectious. One study showed there was no correlation between those who had lots of symptoms or even died from it compared with those who had almost no symptoms. In other words, that didn't connect to how infectious they were to others. Furthermore, children can spread it at the same rate as adults. There's been a lot of debate over this issue, but again and again, epidemiology has found and continues to find that children are vectors. Dr. Zoe Hyde's Twitter is perhaps the best source I've found as a clearinghouse for what studies have shown and how to understand them. In this one, again, 70% of people with COVID-19 didn't transmit the virus, but children spread it at the same rate as adults. And this is a huge study of 84,000 plus cases and 575,000 contacts. Children have the same variability in their infectiousness as adults. That is, they can be just as infectious when they are asymptomatic and before they show symptoms. Even youngest children can spread it. Here, a daycare camp was traced, and asymptomatic children passed it to other children at the camp who passed it on to some of their parents and siblings. Once, children were thought to be either immune or not vectors, and this has led to an almost continuing practice of not testing children, especially if an adult in their family had COVID. The assumption was that the adult was the vector, and the testing practice has amplified this assumption, generating false facts. This has continued to the present in the US and Europe. So here is a new phrase. This novel coronavirus is an over-dispersed pathogen that tends to spread in clusters, and few people transmit it, but when they do, it is super infectious, and they don't always know it. Super spreading is the result of this. When someone, often before any symptoms, is temporarily super infectious and in a situation where others will share their error for a prolonged period of time. And you can go to stopsuperspread.com to see some very good infographics. One family gathering, all of the inner circle got COVID, and then they spread it to others. Note that one of the secondary vectors is a 9-year-old child who spreads it to 2 of her grandparents, one of whom then spreads it to an 85-year-old neighbor. Another person was a healthcare worker who passed it on to 3 patients. Others spread it at work. Here's another way to think about super spreading events. A nightclub and a boxing match in Thailand resulted in all of the inner circle red dots being infected, but not the green dots. The main difference was that wearing a mask reduced the risk of being infected, and the type of mask did not matter, but they did have to wear it consistently. In other words, inconsistently wearing a mask does not help. Masks also affected the behavior of wearers, who maintained better distancing. And also note that, again, most of the infected did not go on to infect others. So here's a summary of what made COVID so deadly: the interaction of treating it like a different virus than it is. And this is a key part of why public health messages were and are contradictory or wrong in the countries where it's out of control. And I think of these as paradigm differences. First, that you're infectious before symptoms. Second, that asymptomatic people can spread it. Third, that most people don't spread it at all. Fourth, even spreaders don't spread it most of the time. And, really important, they need to be in an enclosed space with lots of others for a while to spread it when they're infectious. Fifth, severity and mortality don't match infectiousness. This includes kids spread it but are often symptomless, and they're ignored as vectors. There are no correlations yet to who spreads it, and it spreads rarely but severely and usually secretly, and this is terrifying. Together, these make a perfect sweet spot for unknowing transmission and the perfect sweet spot for super spreading events. So I'm going to stop here. There are so many other paths to research in other talks, including the politicization of all of these facts, long COVID, treatment, vaccines, and so on. Thank you.